Hello from the Leonard Davis Institute at University of Pennsylvania. I'm Allison Buttenheim, and we're here with Covered, COVID Vaccine Equity Research Dialogues. I'm here with Professor Harold Schmidt at the Perelman School of Medicine, and our guest today is Dr. Paul Delamater, Associate Professor of Geography at the University of North Carolina. Paul and I are longtime colleagues working on the childhood vaccine acceptance problem, and he is an amazing spatial analyst, map maker, thinks about all things spatial. Our topic today is whether vaccine allocations should respond to both vaccine supply and vaccine demand dynamics, including a potential fourth surge that it looks like we're facing. So it's early April. We're still a month away from President Biden's May 1st fully eligible deadline. But in some states, available vaccine appointments are going unfilled. In other areas, people can't get appointments. And we know disparities of all kinds are emerging from that, supply constraints. And on top of that, it's pretty clear that cases are resurging. What was some very localized resurges now look to be a generalized fourth wave coming. So the question that I'm going to pitch to Paul and to Harold is, should vaccine allocations be adjusted downward in places where there's low demand? And should we be pulsing or increasing those allocations to places sort of hotspot breakout areas? Paul, what are your thoughts?
One of the first things that I've been thinking about is that there's many parts to this issue. There's allocation, there's eligibility, and then there's actually distribution to people. And so thinking about just first off allocation, I think that that's actually getting ahead of things a little bit. And I also think about this idea of hotspots in that we're seeing the past. Every time we see up-to-date data, we're seeing the results of something that happened a week, 10 days ago. Now, hotspot now is likely to keep going, right? And so making sure that we're focusing efforts there is important. But to be honest, I don't know if sending more vaccines or allocating them is fast enough. I think it might be the non-pharmaceutical interventions that we have to double down on.
So Paul, I totally get your point that in terms of allocating to hotspots and upping the allocation beyond pro rata population based, we're seeing the past. But what about places where demand is falling and where we're allocating to places that can't get that vaccine in arms because there are no willing arms?
That's a really interesting question. And that, I've been kind of wrestling with the ethical dilemma on this, right? About what's equitable, right? In kind of the idea of not supplying vaccines to people that are eligible for them. And I don't know right now I'm struggling to think about what we should do with that, because you don't want the vaccine just sitting there, right? And especially when, like you said, there are places where you can't get an appointment. And so thinking about this is, it's not just an ethical question, it's also a question of distribution. Do you actually go and get the doses from places and move them other places?
And Allison, in a way, to Paul's point just now, I think there too, we're seeing the past, right? If we see low vaccine uptake, what it is that we see a lack of engagement that should have preceded that situation. So I think for me, one of the key lessons there is let's get ahead of the game, especially as we're rolling out vaccines to the entire population, and make sure that where we have good reasons to know that people may be reluctant, oftentimes for good reasons, to take vaccines, we engage with communities and we have the ground game to make sure that we anticipate those kind of situations rather than say, well, too bad, we offered them vaccines and nobody came, right? That also is just a look in the past and one that reflects that we haven't engaged as much as we should have.
Paul, you've really been amazing over the whole past year in tracking the pandemic, specifically in North Carolina, where you live. First, it was testing and cases. Now you've moved into tracking vaccines too. How do you think about this as a geographer? When we try to answer these questions about where should allocations go and should we up them or down them, how does a geographer think about that?
So how a lot of other researchers split people and populations into subgroups, maybe based on race or based on age groups. A geographer's first inclination is to split people up by space. A map of North Carolina is very heterogeneous, where there's lots of variation from place to place, even to the most simple thing of like, where do people live? We have places, massive cities, and teeny towns and rural regions. Geographers think about this kind of from the initial thought of um, where are the people at, and especially with health issues, I joke about this, where are the sick people? Like that's one of the first things we have to understand, right? Where are people getting sick? The vaccine question, thinking about this from an equity perspective, is, where are the populations that we need to reach? Not just who are they, and I think a lot of people have been thinking about who, but I think about where are they?
Paul, how have you been able to engage with state policymakers in North Carolina? I mean, you really produce these incredible dashboards that paint these really important pictures, and there's time elements and space elements. Has there been demand from state policymakers for those data? And
Really, when I started this a year ago, I was thinking about value add, because the state has their numbers and all their maps and this and that. And there were things that I couldn't find on the state's dashboard that I wanted to know. And I always thought there were like adults in the back room, like with the data and making decisions and all this. And I found out that that's not true. And so that I just was like, I have to calculate it. I have the skills, I can do it. I have the time. So I put the dashboard up, or the website. I think they've seen it, but I don't get any requests for anything. If that's what you're thinking about.
And as you started adding vaccines to the website, again, having tracked testing and cases and school reopenings, you were really out in front in providing information. How did you decide what aspects of the vaccine rollout to show?
Well, one of the first things I tried to do was I was trying to calculate like percentage of people who were eligible per county, but that turned out to be a very difficult problem to figure out and calculate how many people were eligible.
Well, especially with the health condition related, the chronic condition related.
And even the essential worker condition. And I ran into some problems really quickly. And one of the things I'd noticed on the state dashboard is they were doing all their calculations based on total population. What percent of everyone has been vaccinated? And I was just sitting there saying, hey, like 18-year-olds, and some 16-year-olds are, they're not eligible to be vaccinated under those ages. And I'm like, again, thinking like a geographer, and that varies from place to place. There's some places that are very young. There's a lot of people under 18, and some places where there are fewer. And so that was one of the first things I did, was just said, okay, our denominator, our percentage that we're calculating from is just of the 18 and up population from place to place. So what percent of that, eligible to be vaccinated population has been vaccinated? So that was one of the first things. The other thing is thinking about this over time. Our state dashboard has a lot of great stuff, but they don't do a lot of tracking rates over time. And that's where I'm downloading the data every day and constructing these spatiotemporal data sets, where then I can show how things have changed over time across space.
This type of analysis, I think, is going to be really critical from May 1st. And, many states are already thinking about relaxing the eligibility criteria before then, of course. The reason we have priority groups and the reason we have phase systems is because we can't trust that if we let people make their individual choices, public health is promoted as effectively as it should be, and equity at the same time. Ethically, the concern as we move towards vaccines for all is that we're collapsing into a really bad form of first come, first serve, or maybe we should better call it first click, first serve. The question really is what the implications are for the rollout, both in terms of epidemiology as well as equity. We really need to get vaccines to people who are a lot more vulnerable. And for example, people over 65, we have just over 50% of people vaccinated. I talked to my pharmacist at the corner the other day saying we're still vaccinating mostly 65 and older, yet we're opening up to 30-year-olds. So in a way, you should be able to use these data and say, look, here's what's happening. By opening, we're seeing a lot more younger people being vaccinated, but we don't see the same trajectory in the previous priority groups that for good reasons we did prioritize for the most part. And we need to course correct, right? Isn't that a real unique opportunity of these analysis to continue to make the equity point literally until it's over? And it's going to be a while.
And one of the things I've been the kind of the most upset about is we picked eligibility criteria that we have terrible data on. That it is very difficult to measure some of the eligibility criteria that we've used. I'm concerned as well that we are moving through the phases, whatever states have in place and counties have in place, without good data backing up should we be moving to this phase, that we are looking at numbers like maybe percent of appointments going unfilled that aren't taking into account things like, do the population which we're trying to reach right now have access to computers? Do they know how to set up an appointment? And I really do worry about that because, like you said, like if only 50% of the people 65 and up have been vaccinated, we probably shouldn't be opening up vaccination to 30-year-olds and above, right? We should really be redoubling our effort to get our priority groups vaccinated.
I do think, the Biden administration with the recently announced push to get more vaccine to pharmacies of all types, not just the big chains, but to local pharmacies, that seems to be driven by the recognition that this really does need to be place-based, that, way more people can get to a corner pharmacy than can get to a chain pharmacy or can get to a big stadium or convention center for a mass clinic. But, the idea of, do we have the data to even answer the questions of how big are our eligibility groups is huge.
It's come up throughout the pandemic for me as a data analyst and a secondary data analyst is I can only analyze what I have data for. And sometimes there are these questions that are just unanswerable. We just don't have the information for them. And it's sad. Honestly, when I kind of threw in the towel on trying to figure out the eligible population as North Carolina moved through phases, it was sad for me. I'm going to go back to it because now I've got all this time series data and I really am going to analyze this at some point. Like, how did we do over time? But a lot of what I'm doing right now is I'm not thinking about publishing. I'm not thinking about, I'm just trying to get information out that I know eventually there's going to be 20 papers that come out of all this analysis from my website. But right now I'm just thinking like, get information out, anything I can. If people use it, great. But I don't know.
Yeah, this is exactly the trade-off that we have, right? As academics, we really want to get this absolutely right. We want to get these overlapping groups problems. We want to, really know what the situation is and then develop a response in light of it. But I think that's too where we just have to be mindful that the perfect shouldn't be the enemy of the good here. And we in many ways, we simply know where most people died from COVID. All those things are place-based. We know where most infections are. So that's, I think, where we can abandon some of the perfectionism and just say, look, this is where place-based measures work.
The one that I keep struggling with is the making appointments online and that I just keep seeing mostly on Twitter, just horror stories of how difficult it was. And, really kudos to the people that have been helping out some of the populations with, I see some of my friends, like I made an appointment for my neighbor and things like that. It's just amazing that people have been doing that. But it's like, why? We have so many resources and we've solved, look at how fast these vaccines got developed and ready and out. Like, I'm sure we can figure out a better way to get people to the site to be vaccinated or bring the site to the people.
I think that's a great place for us to wrap up today. Thanks to Paul Delamater from the University of North Carolina, health geographer, who helped us think about these vaccine rollout from a spatial angle. Along with Harold Schmidt, I'm Allison Buttenheim from the Leonard Davis Institute, and this is Covered, COVID Vaccine Equity Research Dialogues. Hope to see you here again.